Good afternoon, ladies and gentlemen, and welcome to the Patient Activation Impacting Healthcare Quality Improvement Conference Call. Your host for today is Gloria Pizzo. Ms. Pizzo, you may begin.
Good afternoon, and welcome to today's webinar presented by the Lake Superior Quality Innovation Network. Lake Superior Quinn is comprised of three organizations: MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. And I'd like to introduce you today's speaker. Craig Swanson is the co-founder and president of Insignia Health. Insignia partners with health systems, hospitals, insurers, public health providers, and pharmaceutical companies to help individuals become more active self-managers of their health and health care. And at this time, I'd like to turn it over to Craig Swanson. Thank you, Craig.
Great. Thanks, Gloria. Thank you all for joining this lovely mid-January afternoon. We'll go through a little process here to talk a little bit about the patient activation measure, what activation broadly means, how you can use that in your world to engage and understand with the patients that you're interacting with, and use that information to provide a more effective, more interactive engagement with each of the patients. I wanted to start with one very broad sort of macro view of the world, just to level set where we are and what we're talking about. We know from lots of different studies in different environments, and you'll see, maybe slightly different data. This is the graph I'm showing is from the World Health Organization in 2007. But it's this idea that there are some major determinants that are driving what's going on with health. The way we look at the world, and the things we really want to focus on today, are really two big components of that. And those are the things that we as individuals, we as patients and consumers, have an ability to influence. We might not fundamentally change it, but we have the ability to influence two areas. Broadly speaking, our lifestyle. Do we choose to smoke or continue to smoke, as an example, even though some of these are addictive behaviors? Do we choose to manage our diet or exercise or blood pressure or alcohol use, etc.? Do we choose to let those things go? How engaged are we in managing those things? How able are we to problem solve around them? And the same is true with our environment. Do we choose to live in certain areas or not in other areas? Do we problem solve around some of the issues we may face in the environment we live in to try to live a more healthy lifestyle? And these two things combined represent about 70% of the $2.6 trillion we spend in healthcare today. So we have the ability to influence those things. We don't have the ability to not necessarily fundamentally shift those, but we do have the ability to influence them in a very meaningful way. And what we do at Insignia is we look at that world and we take this patient activation measure, an activation-based approach, which is widely discussed in the industry today. And we look at this, how do we help people? Well, we use a tool we call the patient activation measure to empirically measure where people are, to really understand, not just on a subjective personal level, but on a quantifiable individual level, who is this person and how capable are they? And we use then that measurement to know how to interact with people and to know how to help them along a path to improve their self-management skills, to improve their ability to engage in their health, and to become more engaged in their health and get healthier. So that's the focus of what we really want to talk about today around this concept of activation. How much can we help people become better self-managers? Most of what we'll talk about is centered around this concept or this idea we refer to as the Patient Activation Measure, or PAM. And this is originally a tool that was developed at the University of Oregon about 15 or 16 years ago. And what's neat is, for something like this that's come out of an academic environment, is it's been now used in more than 235 third-party peer-reviewed published studies covering about 40 countries, 42 languages across diseases, conditions, diagnoses, states of wellness, and all demographics, if you will, so age, gender, income, education, literacy levels, etc. And what's really powerful about a view of activation, as you think about your patients and interacting with your patients, is that when you have an activation view, it gives you a view into how capable is this person. And what's fascinating is their demographics, their age, gender, income, education, literacy level, don't play a meaningful role in your ability as a provider, as a doctor, a nurse, or a coach, to know how best to interact with the individual. What PAM does is it gives you an ability to say, I know within a couple minutes how to best interact with this individual and to use my time as the doctor, nurse, coach, and to use your time as the patient to drive the most effective outcome in this interaction. And this has been used in lots of places. You can see by the couple bullets here that this system and methodology has been used in everything from clinic operations to vertically integrated systems to health plans to pharmaceutical manufacturers, medical home environments, all sorts of environments that we really see in this world today. And PAM has been very effective in each of those environments. One last sort of broad view, I mentioned that PAM's been used in 42 countries and across conditions and cultures and languages. It's also obviously heavily used in the United States. So we have people in it's actually about 42 states where there are delivery systems that are using this methodology. There are certain states and federal agencies that actually mandate use of this tool in different environments. So Medicaid obviously is where states get involved. The most recent rollout is the state of New York, where they're mandating use of these tools across a couple million Medicaid members. And then we have other things too, like CMS has included the patient activation measure in a very small, narrowly focused portion of the Affordable Care Act, specifically focused on readmissions, and NHS England is rolling it out across the system. So the reason I mention that is just that this is not a, this is not a flash in the pan flavor of the month. This is something that is fundamentally shifting the way people think about health and interacting with patients and helping the patient drive to more effective care. So let's talk about this PAM instrument itself, and what does this mean? So let's give you some perspective of what this thing is. The patient activation measure is a 10-item survey. So there are 10 really statements, or you can call them questions, that we give to the individual. It's self-report, and the individual answers those questions, and based on their answer categories and their patterns, we're able to run that through what's called a very sensitive statistical methodology called ROSH, and that allows us to do something that's very, very cool and very different from everything else you see in the world, and that is actually that little teeny line of black text at the top that says interval level measurement in a 0 to 100-point scale. And this becomes very important when we start getting a little deeper in the conversation, that we're able to put each individual on an empirically derived what's called interval level scale, meaning we can put each individual on a ruler, and that ruler has 100 points on it. And we know when we have a PAM score on somebody, this goes way beyond a qualitative view of how capable is this person. Instead of saying this person may be high, medium, or low, we can instead say Craig takes PAM and scores 52.3 on this 100-point scale. And we know exactly what that means about Craig in terms of his ability to engage in his health, how much energy and effort it's going to take us to work with him, and we also know when we move him even 1 point on that 100-point scale, what does that mean predictively about him? So, for example, when Craig takes PAM, we coach him for a couple months, and then he takes it again and he scores 53.3 or improves by 1 point 3 months later. We know what that means predictively. It means there's a 1.7% declined probability of a hospitalization. There's a 1.8% improvement in A1C control. There's a 2.1% improvement in my management of my viral loads if I have HIV. I can go on and on. So it's very exacting and very scientific about what we can predict and what we can measure about an individual. And we use that 100-point scale and the behavioral groupings that come out of that, and we drive people into these behavioral groupings that sort of show up in the data, and that is people who are score low on PAM are level 1s, and behaviorally they all look the same. So interestingly enough, level 1, we have a real mix of people. We have people who have comorbidities. We have people who are well. We have people who are highly educated and wealthy. We have people who have low literacy and are below the poverty level. Behaviorally, in terms of how they manage their health, however, they all look very similar. Level 1s are not engaged in their health. They're not self-aware. They don't view that their role is significant, and they have a hard time understanding that things they do play a role in how they feel. They prioritize other things above their health. And you can see by the little quote at the bottom there, a lot of these is actually a real verbatim from a level 1 patient who said, my doctor's in charge of my health. I really don't play a role in this. And so level 1s are people who you've probably seen before who maybe believe that when they had an inpatient visit that they were cured. So they maybe had an inpatient visit around CHF, and their view of it was, well, I don't need to take meds after that because my doctor cured me. Not engaged in their health, not self-aware, not good problem solvers. Level 2s are people who have some knowledge and skill about their role, but they lack the confidence to pull it off long term. So an example of a level 2 might be a patient who was maybe, let's say, newly diagnosed with diabetes, and you bring them into the clinic and you work with them and you show them how to prick their finger, and you even get them to do it while you're with them. And they understand, they nod their head and they say, yes, I understand I should be doing these things. And then you say, great, let's follow up in 2 weeks. And they come back in 2 weeks and you ask them, how did it go? And they kind of shake their head and they say, well, it didn't, because when you weren't with me, I was concerned that I was going to hurt myself, I was going to bleed, I was going to have a problem with it. I knew I should be doing it, but I wasn't able to pull it off when you weren't with me. So that's kind of a classic level 2. And it's really not until we get to level 3s when people are able to tie together knowledge, skill, and confidence, can take action on their own, can handle the concept of, the conversation around, and the pursuit of evidence-based medicine and guideline behaviors for self-care. So what I've just said, or the opposite of what I just said, is that level 1s and 2s are not able to handle that conversation. And they're not able to handle it for really one of 2 reasons. One, they're not self-aware, they don't understand their role. Or 2, the behaviors we ask them to take on are too difficult. They don't understand. And so they don't do it, and we get frustrated with them. And it's very frustrating. These are sort of the intractable patients, if you will. And I'm going to show you how we identify these people and work with them in a way that not only reduces your frustration as a provider, as a doctor, a nurse, a coach, but also helps to engage that patient better. And then level 4s are people who are highly engaged in their health, highly self-aware, by no means perfect, but know that they play a role in managing their health and they're pursuing things. So let's peel this apart one more layer, just to give you a little deeper perspective into what this looks like, and then we'll be able to kind of walk through some scenarios. This is what we call a behavior map, and this one happens to be about diabetes self-care. We have hundreds of these showing what is the difficulty structure of behaviors by level of activation. And so in this example, or this data set, if we use the example of a level 1 patient, which would be the maroon bars, those are level 1s and 2s, the greens are level 3s, the yellows are level 4s. So remember, level 1s and 2s are not engaged in their health, they're not self-aware. Level 4s on the gold are pretty engaged in their health, they understand their role, and they can pursue these things. But if you're walking into a patient room and you have a level 1 patient in there who has diabetes, and you know nothing else about that person, you don't know yet, in this example, whether they're male or female, whether they're young or old, whether they're rich or poor, whether they're high or low literacy. What we do know, just with a PAM score, is that on the left-hand side here, they are 57% compliant with their meds. And there's a 90 to 95% predictive reliability around that. We know that as we engage with that person and help them improve their health and they move to level 2, 3, and 4, at level 3s they're 62% compliant, and at level 4s 86% compliant with the meds. The other thing we know that I think is very fascinating is, so you can see within that one behavior that there's a stair-step pattern, how people get better at any given behavior as they move along that activation construct. As they improve their health, they improve their self-awareness and their understanding of their role, they improve how they manage these behaviors. As we move in totality across this graph, however, and we go from left to right, we see these bars are getting progressively shorter. meaning these behaviors are getting harder and harder for people to do. So, and it's even, when we get to the far right-hand side, you can see even for level 4s, these gold behaviors, these managing stress, getting exercise, and counting carbs are hard for level 4s to maintain and manage long-term. So it gives us a lot of insight into which behaviors do we want to interact with each individual on, where they can have success, where they can engage in it, and where they will likely come back either to our phone interaction or our in-person interaction or whatever it is, and asks for sort of the next step. What we don't want to do is we don't want to overtalk their abilities, set them up for failure on a behavior or two we want them to take on, and then their view of it is that they failed, that they knew they couldn't do this anyway, and there's no reason to go back to the doctor's office. There's no reason to answer the phone when the nurse calls. I already know I'm a failure. We want to meet people where they are and what they can handle, and not necessarily where we want them to be, which is the key construct of a patient-centered kind of a world work. And the key to the patient activation measure view of it is we can actually measure quantitatively exactly where they are, what they can handle, what they can take on. One graph table I like to show, and I think a lot of people tell me not to present this because it's terrible. It's a big, messy graph, but I like it, so you get it. And I'm going to describe this and see if I can bring this to life to you. This is a study actually that Kaiser did across 7 regions of the country, and it's about medication adherence, medication compliance. And what they did is, of course, they gave PAM to about 10,000 people, and they followed them. On the left-hand side, left-hand column that says conditions is the primary diagnosis of the individual. And they followed these people for a period of time and looked at claims and also some self-report data and said, what's going on? How do we identify? Is there a way to really predict medication adherence and compliance? And so the way to look at this table, the way I hope this will bring this to life for you, is look down the columns. Look down the column that says level 1. What you see is, regardless of condition, regardless of primary diagnosis, that level 1s, about 30% of them have missed meds in the last week. When we engage people and we improve their level of activation, we improve their PAM score and they become level 2s, that drops a little bit, and 25% have missed meds in the last week. And then about 20% for level 3s and 15 or 15.5% for level 4s. And for those of you who like statistics, you can see the p-values for most of these in this single study are very small, meaning it's the tightness of fit of the data, meaning it's the PAM score that's predicting medication adherence and compliance. It's not the condition. And we can even, sort of anecdotally anyway, look at this and test what I just said and say, so look at something like hypertension at the bottom. Asymptomatic, as you all know, you can live with it for years without even knowing you have it, let alone take your meds one day and not the next and feel fine. And yet, if you compare that in the medication compliance rates to something that I would assume for most people would be top of the mind, like chronic pain, maybe CHF, cancer, arthritis, depending on the severity, what you see is that the medication compliance rates don't change by condition. They do change by level of activation. So it's your level of activation that's giving you, the doctor, the nurse, the coach, insight into what is this person doing, and as I can help them improve, what's going to change in this person? How do they become more self-aware? How they can become better? Hot topic in the country, of course, is readmissions and has been for a while, and this is, I think, a very, very interesting study done by AARP. They did this with people aged 50 and older who had at least one chronic condition. And AARP went out and gave PAM to about 12,000 people, and then they followed them. So this is just an observational study. And they followed them for the course of a year. And during that time when they were following them, a subset of patients, about 1,200 patients, went inpatient, went into the hospital. And that's what this picture is made up of those people who went inpatient during the time of the study. And what they found is really fascinating. So if we start at the top of this graph, what you see is the less activated on the right-hand side are sort of the slate blue bars, are PAM levels 1 and 2. People who are not engaged in the health, not self-aware, don't understand their role. And the more activated, the dark blue, are PAM levels 3 and 4, people who scored higher on the survey, have a reasonably high level of self-awareness of their role and understand what they should be doing. What they found in the study, starting from the top, is that if you're level 1 or 2, you're the 28%, you're more than twice as likely to readmit to the hospital within 30 days of discharge than if you're PAM level 3 or 4. And this data was all propensity and acuity adjusted, so you are very much looking at an apples-to-apples comparison clinically of what's going on with the individual. And the only real difference is somebody's PAM score. Are they PAM level 1 or 2? Are they PAM level 3 and 4? And you can see how this would work. If you're not engaged, not self-aware, you're not following up on things you're supposed to be doing post-discharge, and you're much more likely to readmit. And it was actually this study that led CMS to do 13 demonstration projects around the country, a number of which used PAM, and then ultimately led to putting PAM in the Affordable Care Act. And you can see how this crescendos as you go down. People experiencing medical error at nearly twice the rate, level 1s and 2s, having poor care coordination and suffering a consequence of that, and ultimately checking out of the system in total. And you can see how this could happen. In fact, I talked to Keith Lind, who's the guy at AARP who did this study, and I said, what can you tell me, sort of anecdotally, what can you tell me about this and what you saw in the data when you did this study? And he said it was fascinating and very, very simple, and that is that if you take two people who look the same, and they go into the same hospital on the same day for the same reason, they have the same surgical procedure or same procedure by the same doctor and the same set of nurses, they have the same length of stay, and they discharge on the same day, and clinically they look the same at the point of discharge. And the only difference is one's level 1, one's level 4. They discharge. Day 2, they both experience some kind of a problem. It could be, who knows, a wound care. It could be maybe their chest feels funny, depending on what was happening to them, what procedure they had. The level 4 patient that's highly engaged in their health picks up the phone and says, hey, doctor, nurse, this is how I'm feeling. Is this normal? What should we do about it? Somebody who's engaged in their health, they're problem solving, they're trying to figure out what's going on. The level 1 patient has that same experience and thinks to him or herself, they didn't tell me this would happen, so it must be okay. I don't know really what kind of questions to ask or what kind of conversation to have with somebody. So if I did know who to call, which I don't, I really don't know what to ask, and I kind of feel stupid asking questions anyway. So I think I'll just leave it alone. Day 5, the problem gets severe, and day 7, that level 1 patient ends up in an ambulance going to the ER and then readmitting, and obviously a very expensive and clinically much more complex situation at that point, than the level 4 patient who 5 days earlier called his doctor, went in for a $150 office visit and solved the problem, maybe by adjusting meds, maybe by having their wound examined, whatever it was, or surgical. So it's a really interesting view into when you look at things clinically apples to apples, but you compare it by PAM level, what's going on and how important it is to make sure that we understand how capable is this person to self-manage, and based on that capability, we want to interact with them differently. One point I wanted to drive home here, and this is actually a study done by QIO in the Pacific Northwest, just post-discharge. So this is a really, really interesting study. What they did is they went into one hospital, and they followed all of the CHF patients in that hospital. And when they discharged them, they did what I would call a normal discharge. They gave them a plastic bag with 14 pieces of colored paper and said, you can leave now and we'll follow up with you. And they followed these people. And day 2 and 3 post-discharge, nurses went into homes to do the follow-up visit and counted pills. So this is a very, very accurate set of data. What they found is fascinating. And it sort of reinforces what I just talked about on the previous slide, and that is that you'll see there's 2 bars here for each level of activation. The first 2 bars on the left-hand side are blue, and those are for PAM levels 1, people who are not engaged in their health, not self-aware, not involved in what's going on. And the first bar that says did not fill 48 at the top of that bar, what that means is within 2 to 3 days post-discharge of what I would think would be a scary inpatient CHF visit, 48% of PAM level 1 patients did not fill their prescription that they were told to fill. Of those, so now moving to the second bar, the one that says not adherent 58, of those level 1s who did fill their prescription, 58% were not adherent to the regimen. Within the first 2 or 3 days, they're already missing things and not following instructions properly. So that in and of itself gives you a huge view into if these people are not able to follow up, take their meds as directed, understand their role in managing these things. Meds, which is one of the easiest behaviors, we know for sure this person isn't monitoring their salt intake, weighing themselves, doing other things that they are maybe being asked to do post-discharge. And then you can see how this tiers down to get to levels 2, 3s, and 4s, and how the fill rates go up significantly, the non-adherence rates go down. And in fact, there's this thing that I'm not showing on this graph, but it's interesting. When you get to level 3s and 4s, a big part of the non-adherence is quite honestly not quite accurate. What it's really doing is there's a big chunk of the non-adherence is due to people who intentionally are not taking it because they have maybe had a side effect or a drug-drug interaction. They went back to their doctor and had a new prescription filled and they just haven't gotten it yet. So they're proactively involved in what's going on. But again, a very interesting view, I think, into why some people are readmitting and why others are not. So now I've given you at least, I think, a quick view into what does it mean when you have a PAM score on somebody, when you have an activation view of an individual, again, regardless of demographic and clinical issues that you may see. A PAM view gives you an interesting approach into understanding how capable is this person and are they going to be able to take these things on. The next thing I think is really important is how do we all live in a world where there are limited resources and limited time? How do we use this information in a way that can help us think about how we structure our days or where we guide our resources and our time and our intervention? And a group, Fairview in Minneapolis, the big delivery system in Minneapolis, many of you are probably familiar with, did a study that's very interesting. This is a peer-reviewed published study. What they did is they historically have used a claims-based view of the world to identify risk. So they looked at the last year or two of claims plus some demographic markers and some adjustments. And they've said, based on that information, we know where the top quartile of risk is, and that's this 25%. So if they looked across their population, they'd be able to look at claims and say, these are the people that are likely to have claims again this year based on last year's claims. And therefore, this is where we should focus our energy and effort. And then what Fairview has done over the years, and they have got a lot of PAM scores, 300,000 or 400,000 PAM scores on the patients, they said, well, this is an interesting view, but let's pull this data apart and separate it by PAM levels and see what happens. And so they did. And what they found is, the graph you now see, when they were able to much more accurately sort of tear this apart and say, okay, claims is interesting, but what does that tell us when we look at this by PAM level? And so what they found is on the left-hand side or in the blue, you found that 45% of the level 1 patients are in that top quartile of risk. What's also interesting is that looking at claims only missed 55% of level 1s who either didn't have claims last year or didn't have a stream of claims that led them to be quartile in the top portion of risk, or they didn't have any claims at all. They maybe are new from a different moving into town or something, so they didn't have any information on that individual. So they missed those people. The other thing that Fairview said I think is very interesting is they looked at this and said, look at the people who are level 3s and 4s, the green and the yellow on the right-hand side. And the top of that graph, the 24% and the 19%, these are people who, based on claims, probably have comorbidities, are sick, are managing chronic conditions, and they are spending money, and they are not perfect at what they're doing, but they're pretty engaged and pretty involved, and they're doing a reasonably good job of their self-care. So our ability as Fairview to fundamentally change them is limited because they're already pretty good. So we should make sure that we focus energy and effort on the level 1s in particular and the level 2s to some degree patients who are not engaged, not self-aware, who at some level are really the train wrecks waiting to happen because they don't know, they don't understand that they can avoid some of these things. They can proactively engage. They can prevent issues from happening. So it's a really interesting issue of how do you take a population and look at it and refine it more to identify exactly where do you want to spend your time and energy and effort and your resource. Once we do that and we can identify the populations we want to go after, and we then can have an understanding of what the PAM level is, then maybe the most important thing arguably is what I would call the so what. Once we have that information, if you can't do anything about it, if you're going to measurement for the sake of measurement, that doesn't do you any good. But the good news is with this kind of approach, with understanding activation, it can change. So unlike my demographics, I can't change my demographics, but I can change, or you can help me change my level of activation, my ability to engage in my health, my self-awareness, what I'm trying to do, how I problem solve. And you can do it all in a way that's within the construct and the confines of what you're already doing. This is a very light overlay, behavioral overlay, if you will, on top of what you're already doing. The broad construct of this looks like this. Level 1s are not self-aware, not engaged, not involved, not confident. Level 2s, we want to focus on knowledge and skill development and grow that confidence. And at level 3s, pursuing some guideline behaviors. And at level 4s, achieving those things and maybe even exceeding those guideline behaviors. And I'll give you a little story. There's a big delivery system that has used this and has found a really interesting sort of anecdote where they had two people who, one never showed up to the doctor's appointment on time, and in fact canceled half of them or just didn't show up at all. And the other one who showed up for all of her appointments. And they brought both these people in and they were trying to interview them and trying to understand what was going on and were there social determinants that were driving things, what was happening with the individuals. Well, it turns out that one was a level 1, the one who never showed up and was having a hard time getting there. And the level 3 was the one who made it to all her appointments on time and was able to follow the doctor's orders. And then when they started interviewing these people, they said, well, why is it to you the level 1? Why is it you never show up to your appointments on time? And this person said, well, I don't own a car. I don't live on a bus line. It's too hard for me to get there. I can't make it. It's not my problem. I can't get there. So there's a bigger social problem happening with this individual. And then they interviewed the other person, the level 3, who said, well, I don't own a car. I don't live on a bus line, but my health is a top priority for me. And I problem solve around these things. I run to one of my neighbors, I find out when they can drive me to a bus stop or to the clinic, and then I make my appointment on that day. And so my health is important and I prioritize that. Well, in the end, it turns out these two people lived in an area where the front doors are about 60 feet apart. So it is not, the interesting thing here is PAM gives you a great view into how capable is a person, how much can they problem solve. So in that example, there was a problem-solving issue for the level 1, and we were able to work with that individual and get them to learn how to problem solve around it. There are clearly other issues, certain levels of poverty and other kinds of things that PAM can't solve for, and the individual, no matter how engaged they are, and no matter how good their problem-solving abilities are, they might not be able to solve it. So I don't want to dismiss that at all. But it's an interesting view into who can problem solve and why. And we've also done quite a bit of work with PAM scores and poverty levels and understanding what the relationship is. And interestingly enough, people at the same level of poverty but who are at PAM levels 1, 2, 3, and 4 have very different levels of adherence to the medication. Level 1, at the same poverty level as the level 2, 3s, and 4s, will take their meds at about 20% of the rate and say that they can't afford them because they're not prioritizing other things, or they are prioritizing other things above buying their meds. Level 3s and 4s do the opposite. They'll say, my meds are important to me. I'm prioritizing that money above other things. So it's just another sort of anecdotal example that I think is really important to understand when you have these levels of activation. And when we do that, we want to be able to interact with people in a way that's appropriate. So specifically on the right-hand side here, we want to be able to tailor interactions. So when you, as a doctor or a nurse or a coach, have decided what you want to do clinically with this individual, Somebody's in front of you and you've decided what you want to do clinically. Now we say, okay, if we have a PAM score, how do we get them to do that? How do we get them to be self-aware of their role and to take on some of these behaviors we want them to take on? And so on the right-hand side gives you a couple examples. This first person, Manny, you can see by the black diamond on the level 1, 2, 3, and 4 on the bottom there. He's a level 1. And what we really want to focus on is building some base level of knowledge and understanding, helping him understand the role he has to play. And for many places, for level 1s, it's as simple as, do you recognize you have this condition? Do you recognize you play a role in managing it? And at level 2s, we're closing knowledge gaps and strengthening some of their skills. And at level 3s, we're striving for 100% adherence to guideline behaviors. They're not going to hit it, but they understand they should be striving toward that. So we want to treat those people differently. And what we do and the way we deliver that, and this is the sort of the light overlay once you've clinically decided what you want to do. In this example, I'm going to move my mouse and see if you can see this, but if you're coaching Craig, and Craig has diabetes, you click on diabetes, and then he's a level 1. So on the left-hand side, you click on level 1. And it opens up this area in white that says condition and symptom awareness, medication compliance, diet, nutrition, physical activity, stress, and coping. So when you have decided what you want to work with me on, you've decided, Craig, I want to work with you on your diet nutrition, you click on diet nutrition. And now 2/3 of the screen opens up on the right-hand side. What this is giving you is goals and action steps that are appropriate for me, Craig, the level 1 diabetes patient, relative to your clinical objectives of helping me improve my diet and my nutrition. And the key here is not that there's any new news in here for you, the doctor, the nurse, the coach. What it does, though, is it makes it very simple to know, how do I make sure I meet Craig where he is in his ability to engage in this conversation, and I don't overtalk his abilities, because that will shut him down, and he will fail at it, and he won't come back. So it layers in a neat view that says, here's how we message your clinical objectives, here's how we message it. One of the things we hear from physicians and nurses a lot is this is a great tool because it now allows me to objectify my relationship between me and my patient, and it's no longer that the patient isn't doing what I want them to do. It's not a frustrating relationship. Instead, I now know Craig's a level 1, so if he's not self-aware, I need to interact with him at his self-awareness level first before I try to get him to do all these things we need him to do. There's an e-health tool as well, and it's all tailored to levels of activation. Everything in there, articles, videos, tip sheets, all sorts of things are tailored to the individual's level of activation, and that's really important. What we see over and over again is the world of sort of content for consumers, if you will, for patients, is a one-size-fits-all. And we know that doesn't work. You have to meet people where they are, not where we want them to be. And that's a hard thing to do, and so every interaction has to be tailored to the person's level of activation. And when we do that, we know we're going to drive significant changes. There are a number of third-party published studies. This is one. But the key here is this happened to be a control and an intervention group. But for the intervention group where they measured with PAM, and then they intervened using our coaching tools, so guiding that intervention to activation level appropriate behaviors for the individual, they drove all these things from the right-hand side. So the patients engaged more in their health, they got healthier, and they used less unwarranted care. And so the things you see on the left-hand side is sort of what I would call the business outcome. 22% decline in unwarranted ER visits and a 33% decline in unwarranted inpatient visits. We did see, and you will see, improvement or increases in medication compliance, increases in primary care visits, and other things that we would want. All the things you would want to see when we interact with people based on who they really are drive great engagement and behavior change. This is another similar construct as the primary care medical home environment, but the same thing holds true. When we focus on who the individual is, we can really improve a bunch of clinical markers in them, get them to engage more in their health, become healthier. In this example on the right, the graph, a little bit hard to read, but basically there's a green horizontal line and a red horizontal, and then that's largely a pre-post measure of ER visits for this clinic, this primary care medical home, and they had about a 30% decline in unwarranted ER visits for this group. So the idea of meeting patients where they are is really important, and having an activation understanding of that to drive that change. It can be very, very effective. There are a bunch of ways that these things can be integrated into your tools, into your EMR, into other tools that you're using on a daily basis. Lots of ways to do that. And obviously, as you know, whenever you're making a change like this, even though this is a very light behavioral overlay on top of what you're clinically doing right now, and it really doesn't take any time, it is important to make sure that organizationally you're designed and thinking about this and making sure that you're focused on how do we interact with patients and not necessarily being solely focused on what is the condition and how do I treat the condition. Clinically, obviously, that's terribly important. Behavioral, in terms of how do we get the patient to take on some of these behaviors, we need to have an activation-based focus. So I'm going to end there. I want to thank you all for listening in. I'm going to hand it back to Gloria at this point and see if there are any thoughts or questions from anybody.
Craig, thank you. I found that fascinating and very powerful, and I can see how it could be profoundly impactful at an organizational level to drive changes. I'd like to, just before we go into the Q&A session, let our audience know that our slides will be available on the Lake Superior Quinn YouTube page within the next week. And at this time, let's pull up some evaluation questions. And for our audience, will you please take a moment to let us know how we did by filling these out. Operator, can you open up our lines now for the questions and answer period?
Ladies and gentlemen, if you would like to ask a question, please press 1 on your telephone keypad. Again, if you would like to ask a question, please press 1 on your telephone keypad.
I also would like to add that you can type your questions into the chat box as well.
Our first question comes from Michelle Dane, Fairview. Go ahead.
Hi, my name is Michelle James. I work in transplant in Fairview. Although I'm aware of the other Fairview data that you showed, which is fascinating as well. My question as I've been reviewing this is, have you found any literature or any opportunities to move people? Yes, you're meeting them where they're at their PAM level of 1 or 2 or 3 or 4, but in the lower levels, have you found that you are able to, by utilizing the interventions you're describing here, actually move them up in levels?
Yes, thanks, Michelle. That's a great question, and I'm sorry, I probably didn't address that well. The short answer is yes, and what happens is when you measure somebody with their PAM score and you interact with them in an appropriate way, we will see over time, usually anywhere from 3 to 12 months, depending on the frequency and the intensity of the interaction, that we will move people. And we'll move them usually even more, or I should say the greatest movement you'll see is with level 1s and 2s, just precisely those people who you'll want to see the big movement with, where they will move anywhere from, it's about 6 to even up to 18 points on that PAM score. And that's predictively meaningful because remember each point is worth, call it 1.5 to 2 points of improvement in just about any behavior. Medication compliance as an example is a 1.7% improvement for every 1 point in PAM score. So when you're moving 10 points, you've got a 17% improvement in medication compliance. Those changes in PAM scores do then manifest themselves in the following, say, 6 months or so in claims runout, if you will, and improved health. So most importantly, we get people to engage more in their health, get healthier, and use less care. So they do change.
Okay, I have a couple questions in queue. But before I do, Emily from WebEx, would you please pull up the evaluation survey? So in chat, we have one question, Craig, for you that says, how is the PAM administered?
So PAM can be administered a number of ways. So it can be done on paper, say in the clinic when somebody walks into the clinic, you give them a clipboard to fill out their insurance information. You can put PAM on that as well. PAM can be done through IVR or interactive voice response. It can be pushed out through your EMR, through things like MyChart or other kinds of patient portals that you have. It can be done over the phone, administered over the phone. And obviously it can even be done in person, sitting one-on-one with an individual and administering the survey that way. So lots of different ways that it can be administered.
Okay, I have a couple more questions in the chat box. How has this tool been proven to be culturally appropriate across various countries, and what is the use of PAM in developing countries?
Yeah, the great question. So PAM has been used in, I think it's 42 countries at this point. And so it has been used in countries that are developing, so India, obviously portions of China. We see it in other places as well. And what we'll see is initially over the last maybe 3 years or so, what we see is I don't want to get too scientific on you, but the measurement properties of the instrument hold true across cultures. So in other words, the way somebody answers the questions in India and their answer patterns and the way they think about things are the same way they would do it actually in the U.S. And so we're tapping into an underlying construct of who we are as humans, and it's not meaningfully influenced by things like languages and cultures, which makes it very, very powerful. We don't have yet a longitudinal study in a third country about changing those behaviors over time. So we know that the measurement works in other countries. We don't have an interventional study in a third country, in a developing world country yet. We certainly have them in a lot of developed countries.
Operator, are there any questions in queue right now?
Our next question comes from Deborah Smith with Bertram Hills. Go ahead.
Hi, it's actually Barbara Smith. My question was, what type of organizations are using a PAM? Is it more like ACOs and medical practices, or what other types of organizations?
You know, we have people really small stripes, if you will, that are using it. Everything from small clinics to large clinic systems to vertically integrated delivery systems that even have, health plans attached to them, if you will. Health plans use it. Pharmaceutical manufacturers use it. State and some federal governments use it for different things. So it's a wide variety of organizations. And even going the opposite way, for example, in the state of New York, where they're now using this, the public health entity will, in a given region, will run the program, and they are then pushing it out through their community-based organizations to capture PAM and to do coaching. So that could be Catholic Charities, it could be it could be a variety of therapy kinds of environments. So it's widely used.
Our next question comes from Heidi Olsen with Riverwood Healthcare Center. Go ahead.
Hi, my question is, how do you access this tool, and what is the cost generally to use it?
Yeah, so it is a tool that requires a license, and the pricing structure varies based on the size of the organization and based on the volume of patients that you're running through it. So without going into a lot of detail, I'm happy to pass that information along. There's a pricing grid that I'm happy to pass along to Gloria, and she can send to people if you're interested.
Ladies and gentlemen, if you have a question, please press 1 on your telephone keypad. Again, if you have a question, please press 1 on your telephone keypad. Our next question comes from Cindy Schloss with SHIP. Go ahead.
Hi, thank you. It's Cindy Schloss with the State Health Innovation Plan. And thank you so much, Gloria and Craig, for doing this today. It's just been excellent content. I really appreciate the rich and the examples. My question is related to an earlier question that was asked, and Craig, if you could just provide a little bit more detail in terms of how the survey is administered. I understand the different modes, but is it sort of like HCAP or CGCAP where you work with a third-party vendor to administer it, or how are some of the details around that, as well as how the results are compiled?
Sure. So you have all the different modes that you've mentioned, and each of those modes are typically done by the entity, for lack of a better term. So whether it's in a clinic, it could be a nurse or an administrator who is administering that survey. maybe, again, handing the individual the PAM survey on paper or through an iPad app or something, so they're actually physically doing it in the clinic, maybe in the waiting room before they get roomed, or doing it in the patient visit room as well. That's another way to do it. For those environments where somebody maybe is doing this over the phone, that could be a place where a nurse or a coach following up from the clinic calls the individual patient a day or two after the visit and is following up for whatever reason. That could be administered that way over the phone, or a care manager or case manager following an individual can administer the survey over the phone. And then we also have a number of ways that we can put this into different electronic systems so that whether it's the clinic, the delivery system, or the health plan can push this out through their existing electronic channels and administer the survey that way. Each of those environments, every one that I've just mentioned here, except for obviously paper, can be connected to a tool that allows this to be all scored live. So even if it's buried inside of your systems, inside of your EMR, we can score it live so that as soon as the person answers that 10th statement, it immediately gives you a score and a level, a 0 to 100-point score, and a level 1, 2, 3, or 4 on each individual. The paper version obviously requires somebody in your staff or in the clinic or wherever that's taken to input that information into the tool. Does that help?
Ladies and gentlemen, if you would like to ask a question, please press 1 on your telephone keypad. There are no further questions in queue.
Okay, we do have questions in chat that I'll ask Craig. Craig, how often should a PAM be administered? How long does it take to administer? And I'm going to ask the third question, if you can keep this in your memory. Do patients frequently move down from a level 2, 3, or 4, or vice versa?
Okay. So the frequency of administering the survey will largely depend on your objectives, if you will. So the frequency and the intensity with which you're interacting with that patient. So those patients that are coming in your clinic once a year, administering PAM once a year to them is fine, especially if it's for an annual wellness visit or something like that where you're not having a lot of interaction with them. If you're interacting with somebody much more frequently and in greater intensity, somebody who's managing a difficult set of situations, that you may want to administer PAM as frequently as 3 or 4 times a year. So, and that depends to some degree on the subjective view of the doctor or the nurse who's working with that individual and trying to understand, does it feel like this person, so we've got a baseline score, we've interacted with them for a while, does it feel like that person is improving in their ability to self-manage? And if so, let's re-administer PAM to validate that and make sure we change our behavioral overlay of what we're doing to meet that person where they are. In terms of, I think the other part was how long does it take to administer the survey? It's 10 statements. So typically, it's 2 to 3 minutes at most. And then if you're giving it to the individual to have them sort of self-administer, if you will, either through email or through portals, obviously it's, in terms of your time, provider time, it's nothing. And then the last question I think was, do people move up and down? And the answer is yes. Certainly they move up, and that's the whole objective. We want them to move up. And do people move down? And the answer there also is yes, they do. What we'll see a lot of times, especially level 4s, and so let me switch gears for a second to answer that question. Imagine you're teaching a class, and you have kids in your class who are getting A's, B's, C's, and D's. Those kids who are getting A's might get a 98 on one exam, and then they might get a 92 on the next exam, and then a 95 on the next exam. So and maybe even an 88 on an exam. So they're bouncing around a little bit because of different things going on at different times. But they're still basically getting A's, if you will. And the same thing holds true with PAM. We'll see people in PAM level 4s bounce around a little bit because they don't have a lot of room to improve and don't have a lot of room to actually improve their PAM score. For those people who do really go down, who go from, start with, let's say, a level 3 or 4 and go down to a level 2 or 1, we'll see that occasionally. It's usually driven by the idea that when they first took the survey, they were unsure of what they were answering or not clear of, the objective of the survey, and that it really was about providing their doctor or their nurse with good information so they could tailor better to the individual and provide, more appropriate behavioral interaction with the individual. And so sometimes we will see, it's usually about 4%, we will see that happen where there's just for lack of a better term, a bad survey that's captured initially, and then we'll see them drop. And then over time, we'll see that same person come back up.
Operator, you might have one question, one more question for anybody sitting in queue.
Ladies and gentlemen, if you would like to ask a question, please press 1 on your telephone keypad. There are no further questions in queue.
All right, Craig, I do have one final question in the chat box, and they want to know how the PAM compares to other tools that assess patient activation.
Sure. Well, so I'm not aware of, there are lots of tools out there that will talk about assessing patient activation. I've seen lots of them, and I think it's maybe a use of the term activation that is confusing. Our view of the world is a validated tool that understands how capable is this person, how self-aware are they, and from that perspective, I'm not aware of any other tools that do that. So I don't want to sort of dodge the question, but I'm just not aware of anything else in the market. I think it'd be great if other tools did show up, because I think it's very valuable and the world would benefit from that. But there are lots of things out there that are health risk assessments that are more about, how tall are you, how much do you weigh, and do you have this condition, and so they provide you with a different view into the individual. There are other tools that have been around for a long time, like a readiness to change or a trans-theoretical model that's been around for a long time that's really built for addiction, and that is a very different tool. It maybe looks similar on the surface, but it's more about is this person ready to take on a given behavior or an isolated behavior, and that's really measuring very, very different things. So kind of a half answer for you, but we don't see other activation measures as we deem them, or as we define activation in the market.
Well, very good. Craig, we have reached the end of the hour of the webinar presentation. I just want to thank you for a very powerful and impactful presentation today. And thank you to our audience for joining us today for the Patient Activation Impacting Healthcare Quality Improvement. As a reminder, the slides will be available as well as the recording on our Lake Superior Quinn YouTube page within the next week. Be sure to join us for our upcoming webinar, the American Heart Association High Blood Pressure Treatment Algorithm Training on February 17th. And we have an Improving Anticoagulation Care, warfarin, and the Direct Oral Anticoagulants on February 25th. You can register for both of these webinars on the lsquinn.org website. Thank you and have a great afternoon.
Ladies and gentlemen, this concludes the conference call. You may disconnect at this time.